COVID-19 has changed a lot of things. The way we live, the way we work, the way we care for patients. One thing that hasn't changed is Ethicon's unwavering commitment to support nurses, doctors, and everyone who works for and with hospitals. We're looking towards the future and expanding virtual surgical training to educate doctors and clinical staff all over the world. We're focusing our portfolio on the tools that help surgeons and patients. Things like Plus antibacterial sutures, Dermabond Prineo, and Stratafix that help to reduce hospital stays, increase efficiency in the OR, and allow patients to recover at home. And we're accelerating new innovations, including remote wound monitoring. Every day brings challenges and opportunities. We're here, we're ready, and we're in this together.
Novo Nordisk has proven its compassion and commitment to the health of millions. Now, Novo Nordisk is expanding that compassion and commitment to another serious disease, obesity. For many people with obesity, managing the multitude of challenges associated with their weight is a lifelong journey of ups and downs, and a substantial burden on their health. It's time for a new solution. A solution that addresses the problem the Novo Nordisk way by combining science with compassion and a deep understanding of patient needs. A solution that recognizes obesity as a disease and embraces the possibility of dealing with it and its potential health risks in a significant new way, so patients can embark on a new weight loss journey. And this is where it begins. Welcome to Saxenda. Novo Nordisk proudly introduces the first GLP-1 receptor agonist approved for chronic weight management, creating a journey patients can look forward to, helping them lose weight and keep it off. Saxenda. It's about change. It's about hope. It's about a healthier future.
الصبح لما تيجي اول حاجه تستبعد ها؟ اي تتنوم خلاص ها؟
تتنوم اليوم
اي
نعملها كل الوقت
حتتنوم حتكتب لك كل شيء يا هلا يا غرفه كم هي؟
غرفة الفي اي بي
الفي اي بي الفي اي بي هذا تقول
Hi guys.
طبعا ملك هي ولد عيوني الاثنين ان شاء الله هلا حياك الله اهلا الله يحييك الناس كيف اخبارك الله يطول عمرك الله يبارك فيك ويسلمك اقول لك مدام امل انا الان طالع على الزوم عندي مؤتمر عالمي شغال فيه فاعتذر منك اخلص واكلمك على التليفون مؤتمر ساعتين
start.
تكون ذاك لحالة الصورة تماما.
لا انت اضغط ايش هذا التليفون اصبع على سنان خليك جنبي.
Hi guys, can you hear me?
Yes.
ما سمحت رح كل شيء بصير.
Hi. How are you guys? Hey.
Hi.
Oh, Sharif.
Hi, Raul, Sharif, Ramiz, Walid.
Hello.
Hello, you are live, so you can start. Thanks.
Raul, how are you?
Hi.
You look magnificent as usual.
Hi, how are you guys?
I'm fine.
Guys, I guess we have a couple of minutes before we start.
Yeah.
Good, how are you guys?
Can you hear me well?
I'm in my living room.
Dr. Safadi, you are live, so you can start.
No, wait. Can we? I'm live. Okay.
Yep, perfect.
Basim وحشنا.
I guess we can start. So, do we go ahead, Manuela?
Yes, sure. You can go ahead with the introduction, and then we will start with the presentations.
Okay. So it gives me great pleasure to open this session entitled titled Morbidity and Mortality Cases in Bariatric Surgery. We've selected a few cases that will hopefully spark some discussion. We have excellent speakers today, Dr. Sharif Haqi from Egypt, Dr. Walid Bukhari from Saudi Arabia, and Dr. Hassan Hussein Jalamni from Jordan. And we're delighted to have our discussants and moderators, Professor Raul Rosenthal from the Cleveland Clinic in the United States, and Dr. Ramiz Mukhtar from Iraq. So without further delay, we'd like to start with the first case presentation from Professor Walid Bukhari.
Hi, everybody. I'm saying hello to you from Jeddah, Saudi Arabia, to everybody. My best regards. Today, we're going to talk about difficult bariatric revisional surgeries. This is the hospital where I work in. It's called International Medical Center. That's a case mixed disclosure. We do most of the cases. We do 52% of sleeve gastrectomy, 20% of Roux-en-Y bypass, 12% is revisional surgical operations. We do 5% of mini bypass as a primary case, and we do 1% of DS and SADIs, and we do 10% endoscopic procedures related to our surgical procedure. Current or ongoing study in our center, I'm doing series of cases with weight regain, post-gastric bypass with conversion into sleeve gastrectomy. So now the question that comes up says, do you transfer a malabsorptive procedure into restrictive procedure? Well, I was driven to do so by patients actually, and we are getting primarily very, very good results. The first case we did 5 years ago, and it's amazing. But it's very important to do a CT angiogram to be sure that the left gastric artery is preserved. The outcome is promising. We have done until now over 32 cases. Now we want to talk re-sleeve. We want to show a film about re-sleeve state of the art. Of course, re-sleeve, so many things are involved in it. The adhesions, first of all, you would expect a lot of adhesions. You have to check before doing the procedure the presence or absence of migration of the stomach into the thorax, the presence or absence of hiatal hernia, and again, it could be a straightforward rewarding procedures if it is done correctly. The resection of the stomach must be done in a symmetrical way using the proper stapler size for the thickness of the wall of the stomach is of utmost importance. Putting in mind that with some migration, even little degrees, you might have rotation of the fundus and the upper part of the stomach. That has to be taken in consideration when we are doing the resection. So the symmetry of the anterior and posterior wall of very precious importance. Now, in this case, we see that there is some malrotation of the fundus of the stomach. We have to put in mind when we do the cruropixie that in those patients specifically, the aorta could be very, very near to us. And closing the crus or approximating the crus is of importance. Now, closing, here we see that the bursa, when we were doing the dissection, have opened, so we're taking it part of the colopancreatic ligament as a fixation of the stomach into the abdominal hollow. Some people take the greater omentum, but the greater omentum is a mobile organ, and that would not prevent the stomach from migrating upward or twisting for that matter. But taking the ligament propria will minimize the chances of that happening. We could see now when we're putting the tube or taking it out that the stomach is fixed more or less. Laparoscopic re-sleeve of dilated stomach post-band removal and sleeve gastrectomy with intrathoracic pouch. That is a case, you know, where we have again to make sure that we have identified the wall of the stomach and the stomach proper. Of course, the identification of the status of the stomach is done usually by upper GI and by, of course, volumetric CT, and that would be an indication for us when we are doing our dissection. I can only stress, and we could see here using the sonosurge, putting in mind the direction and the position of the active blade, because that could, unfortunately, and it happened to me myself, lead to heat or thermal injury to the muscle and to the wall of the stomach, and that would lead to latent leak. But when you know exactly where you are, you could use it safely. Here we are showing that the fundus of the stomach, and you could see the stitches there have migrated into the thorax almost. Not so much, but that have played a role in the presence of reflux and weight regain. The anatomy of the hiatus is very, very important, and that is something the surgeon would develop with the frequency of cases that he tackles. Most of the time we repair the crura posteriorly, but sometimes when it is so wide anteriorly, I prefer to repair that too anteriorly, and we usually use Ethibond 2-0 stitches to do so, non-absorbable stitches. Again, the importance, in my opinion, of fixing the lateral wall of the resected stomach to the colopancreatic ligament of utmost importance. Laparoscopic gastropixy with cruroplasty of a twisted and herniated intrathoracic sleeved stomach. This is a patient who has had the procedure 1 year before. She came with us with a BMI 15. She could not stay more than 24 hours at home. She would usually go and get IV fluids, correction of disturbed electrolytes. For 1 year, she had to do that. And she was always advised that this is the way it's going to be. She came to us, we diagnosed the slippage, the migration, the twist, and we discovered that the stomach was twisted and have migrated upward. The chronicity of the situation have shown, as we are dissecting, we have opened the left pleura. It's not a big matter. It's important to repair it, and for that we use the V-lock. Not only that, but we were adamant still to release all the chronic fibrous adhesions from the crust and to totally bring down the stomach into the abdominal cavity. And managing to do so, we found that the gastric pouch, there was no real narrowing, there was no real deformity, but the gastric pouch was twisted, and it was migrating the stomach into a large hiatus hernia. Repairing the hernia and the crust is very important, and here we repaired it posteriorly and anteriorly, and again fixing the twisted and migrated stomach into the ligament will make sure that the stomach will stay in place. And the patient was very happy post-operatively, because she said, this is the first time after 1 year I could drink a glass of juice without having to regurgitate it or vomit it. Now, the laparoscopic removal of gastric band and sleeve gastrectomy. We would like to show that removing the band, usually we use a monopolar cutting instrument to expose the covered band with fibrous tissue. Releasing the band is again done easily. The most important part in that respect is to release all the fibrous and fibrinous adhesions that were created by the chronicity of the presence of a silicone-made band. And that, in my opinion, will play a major role in creating a good symmetry of the resected or the wanted to be resected stomach. Prior diagnosis of hiatus hernia of utmost importance. Repairing it is very important to notice that the indirect contact near us in the vicinity is the aorta. Again, symmetrical resection of the stomach, leaving an equal layers of anterior and posterior stomach is very, very important, and that is done by always being conscious of the size of the stapler and the position of the tube and the absence of previous fibrous adhesions. I always like to do a second layer of hand-sewn stitches. Some people see no importance of that. I see it plays and helps in minimizing the bleeding and minimizing the leakage, and we have seen almost no leak in that aspect. Now we're going to talk about laparoscopic reversal of vertical band gastroplasty into sleeve gastrectomy. It is not impossible. Usually those patients are operated in the primary operation as vertical band gastroplasty in a laparotomy and conventional fashion. Releasing the adhesions is not very difficult. Sometimes it is a bit demanding. Important when we are dissecting the band is to remove this Marlix mesh in a 360 degrees if possible. For that will allow the passage of your 36 French tube. It's important to preserve the blood supply to the anterior wall of the stomach where the band have existed for years. Doing that resection parallel to the area where the Marlex mesh was is important. Strengthening it with PDS stitches and fixing the band to the ligament is important. Laparoscopic primary repair of complex leak with chronic gastropleural fistula. This is a hands-on technique. This is a chronic leak that have led to gastropleural fistula that we showed the drain that was there. Patient had many laparotomies, actually had a burst abdomen. We had to close the burst abdomen by hands-on stitching and commence doing the laparoscopic approach. Important to identify the anatomy of the hiatus. Sometimes it could be demanding, but as you see, I use sharp dissection to identify the leak area and to expose the blood supply to that area. And you could see the silicone tube inside the stomach. Now a hands-on repair is, primary repair is done. And we do it in 2 layers using the 3-0 PDS. I don't try to use any sort of diathermy. Here we are fashioning and refashioning the wall of the stomach to have again a symmetrical sleeved stomach and pleural fistula after washing and cleaning and making sure there is no residual collection in the left lung. We fill it up with fibrine glue. The rest is just applying the technical approach. Those patients, as you see, and what makes it difficult, especially in the complex revisional surgery or treating complications of bariatric patients that involves leaks, either acute, chronic, already they have the problem of obesity. The space is not wide enough. So the first problem we are faced with the space that we have to deal with. But as I show and as I've experienced in so many cases, as an advanced laparoscopic surgeon, it is not difficult to work in very small spaces. Laparoscopic esophagogynostomy bypass with high anastomosis in the chest for high complex leak post laparoscopic sleeve gastrectomy. This is a patient, again, as I say, you could see that there is, the space is difficult. It is not impossible. You should not be hesitant. This patient have had also, as we see, there is some blue suture, had the cruroplasty at the same time. The tissue of the stomach was from the medial side and from the lateral side are all ischemic and had multiple leaking points. So the possibility of primary repair is lost. Here we showed the left gastric artery. We're resecting it, and we are going to commence to do an esophagogynostomy. Usually it is straightforward. It's not a big difficult procedure, but in this specific patient, we had a complication of the actual dissection of the lower esophagus and the esophagogastric junction. We had loss of the posterior or deformity of the posterior esophageal muscular wall. So we had to further resect around 1.5 to 2 centimeters of the lower esophagus to establish a circular lumen, and that have made it very difficult actually to do the anastomosis upwards. But as I'm going to show here, it is again not impossible for a veteran laparoscopic surgeon to be able to do that. It will take some time for any surgeon to be able to do that, but with experience and with the right technical ability, it is feasible. So this is resecting 1.5 centimeter of the lower esophagus, made it very, very difficult. We had to actually cut through the left crust to expose the hiatus. As you see, the space is very, very difficult. But again, it is not impossible. This is what I wanted to say. And using the V-lock again to approximate the small bowel to the esophagus, the jejunum to the esophagus, makes it a bit acceptable. Now this is, as they say in German, Winkel of Jammer, or the angle of sorrow. And 2 stitches in both angles, opening the small bowel, opening the lower esophagus, creating the posterior wall with interrupted stitches, strengthening it, passing a large nasogastric tube into the afferent loop, and then doing the hand-on single anterior wall anastomosis will help. But here you have to close again the hiatus to prevent any upward migration of the small bowel when you do the Rulim. This is repairing the left crust that we had to open to have better access to the hiatus, and the patient did very well actually and was all right. This is now talking about laparoscopic bridging jejunal limb for leak, post-gastric band removal and sleeve gastrectomy. This is a patient who had acute leak, and the decision was made to intervene. Patient did not want to lose her sleeve. I want to stress the point that when you accept patients who are coming with removal of sleeve, you have to make sure that you have released all the fibrous ring, the fibrous twists that causes the duplication of the wall of the stomach. So no matter how big the staplers you take, it will give away for a leak. And this is what we learned the hard way. In this patient, we had to release the whole stomach, as we will see, but we managed to preserve the sleeve stomach through doing a loop gastrojejunostomy to create a low pressure passage for the gastric fluids and the fluids that the patient is ingesting, and giving a chance for that area to heal. Now you have a choice when you want to re-separate that junction, or you can leave it, and most 95% of the food that the patient will eat will take the natural and the normal pathway. This is the left gastric artery is preserved. We want just to show it properly. Now repair of an exposure of the hiatus is very important. Getting 2-3 centimeter extra of the length of the esophagus, the stomach downward. We could see here the anterior hiatus, and you could see the lower esophagus. We have gained 2-3 centimeter. It gives you an access. We're releasing it from its intrathoracic adhesions, and here you see the left hepatic accessory artery, and here we're trying as much to get most of the lower esophagus in the intra-abdominal space. This is the hiatus, the posterior aspect of it, and we see now we have managed to get this part of the stomach somewhat easier and lower to do our gastroduodenal bridging bypass. And this is using the V-lock again to create the first layer. Technically, again, it might be demanding, but that's a way out, and it gives you and gives the patient a good chance. That's a roux limb that is connected to the leaked area of the stomach, so it's a sort of bridging Roux-en-Y gastroduodenal bypass with preservation of the sleeved stomach. Angulation of your stitches is very important. The ability to take the V-shaped stitch to take the angles is very, very important, and that is something that is done through proper training. Laparoscopic reversal to Roux-en-Y bypass for leak, post-mini bypass with kink, twist, and obstruction at the elementary limb. This is a patient who have had a band that was removed, then had a sleeve, and with weight regain in both aspects, and then she came for mini bypass, which was performed. Patient came after less than 10 days with a prominent leak. So the decision was made to take down the whole anastomosis. We discovered that the leak is there, it's obvious, and it's at the angle of the gastroduodenal anastomosis. And the reason was that there was an acute angle that was created by the surgeon without noticing. So the decision was to take the whole anastomosis down and transform that procedure from a mini bypass into Roux-en-Y bypass. We noticed that always the space is very narrow, it's very small, but that is really no reason why not to carry out a laparoscopic procedure and not to revert to laparotomy. Here we see that anastomosis established. We are now closing the enteral created defect. In conclusion, the space available in complicated cases is always tight, and that should not revert us to open technique, to conventional laparotomy. The development of good surgical technique should allow us to work in tightest of spaces, in smallest of spaces, yet it must be under full and clear visualization with excellent surgical outcome, as we have seen always. Thank you very, very much.
So good evening, this is the case of a retained foreign object following bariatric surgery. Thank you for sharing this case with me. Disclosure slide, I do mostly sleeve gastrectomy. I do some Roux-en-Y gastric bypass, some omega loop gastric bypass, and revisional surgery. So this was a 25-year-old male patient weighing 116 kilogram with a body mass index of 36 kilogram per meter squared. He's overall in good health. He has mild systolic hypertension on no treatment. He tried numerous diet attempts but failed. And I know the family very well. They come from a line of family history of obesity. And upon his wish and the wish of his parents, we decided to proceed with bariatric surgery. So we did a laparoscopic sleeve gastrectomy. The oozing from the staple line was more pronounced than usual. as I was pulling the stomach out of the umbilicus, there was a hole in the serosa, and some of the mucosa spilled out. So we spent considerable time irrigating the abdomen, removing all the dropped mucosal fragments. And also toward the end of the procedure, I had some bleeding from the upper staple line despite oversewing. So this is a picture of the stomach as it was pulled out of the umbilicus, and you can see the dropped mucosal fragments and the blood that covered the bowels. The picture on the right is the upper part of the stomach where you see significant oozing from the staple line that persisted even though we did some oversewing. So obviously we had to put some gauze in and out to control the blood, the clots, etc. His post-op course was smooth and uneventful, and he went home in 48 hours. I saw him about a week post-op, and as I do routinely, I ordered a gastrograph and swallow. He did not have major complaints. He had no fever. He had some mild pain upon swallowing, which I see frequently after sleep gastrectomy. So I got a call from the radiology tech saying, Dr. Safadi, you really need to come down and see this x-ray. There's something wrong. And as you can see from the gastrograph and swallow, the sleeve looks fine. However, there's something in the left upper quadrant. And that's clearly a retained gauze. Again, these were more x-rays that confirmed the presence of a gauze in the left upper quadrant. So I took him back immediately the same day. Luckily, the time frame was a week, so it wasn't really very bad. I was able to retrieve the sponge without much problems. As you can see here, a cavity was already developing within the omentum. There was no abscess and no evidence of infection. And then so I started asking myself, how did this take place? We went back and did an analysis, a thorough analysis of the case. The first question was the sponge count correct, or was it done in the beginning? And yes, of course, it was done as customary. The second question is, was the sponge count correct? And we reviewed all the records, and yes, indeed, the sponge count was correct. Now, luckily, we had a videotape of the case, and we can, I'll show you what happened at the toward the end of the case. This was the final touches on the upper part of the staple line where, as I mentioned, there was still some oozing. We used the gauze to pad and dry out the blood. You can see here 3 instruments. So there were 2 people working. I was working and my assistant. And around the same time, I got a call from the emergency room saying that there was an ill patient and needed immediate attention. So we exchanged positions, the resident and I. And here in that spot, I assumed that the gauze was being removed and continued working, answering the phone call. It just happened that at the same time, there was a change of shift. This was an afternoon case, and the nurses who were working in the OR at the time were ready to change shift, and they were signing out to the team leaving. So we continue on with this case, more irrigation, and at that time, I assumed that the gauze was removed. There was a lapse of poor communication because at that time, the communication suggested that the gauze has been removed. So we continued the irrigation as I was answering the phone call from the emergency department. The nurses were signing out to one another. And seemingly, as we finished the case, the camera is being pulled out. You can see here that the bleeding was under control. And as we were removing the camera, we could see no visible appearance of the gauze, and the assumption was that the gauze was removed. Around the same time, one of our medical students who was examining the specimen decided to touch the resected stomach, so he used an unmarked gauze and left it close to the specimen. So when the count was, you can see here, no evidence of any cause. So when the sponge was counted, although it was unmarked, it was counted, and that was what led to the correct count. However, it was incorrect. So there were a lot of problems. One, this was an afternoon case. There was above average oozing from the staple line. We had a technical problem retrieving the stomach from the umbilicus, which led to blood mucosal spillage. It added operative time and certainly added stress. The phone call from the emergency room was a major distraction. We changed surgeon position and switched at the same time. We had poor communication with the surgical team members and the scrub team. We were approaching shift change, and as I mentioned, the medical student inadvertently used an unmarked gauze. So this was the perfect example of the Swiss cheese model where several defense mechanisms were disrupted. So retained surgical sponge, or in general retained a foreign object, should be a never event. In the 1980s, it was reported between 1,000 to 1 in 15,000 interrupted operations. In more recent cases, the number has dropped down to almost 1 in 19,000. It still has not reached zero. So what's the significance of a retained foreign object? This was a study by Dr. Gawande in the New England Journal of Medicine. And you see, as you can see, this is a pretty grave complication. Out of a series of 54 cases, there was 1 mortality, 2% mortality rate, a significant high rate of hospital readmission, a significant high rate of sepsis, infections that could lead to fistulas and visceral perforations. So this is really a very serious event. Some of the risk factors which probably applied to our case: operations performed on an emergency basis, no. A body mass index which is high, which applies to our case. Unexpected change in operation, which was happened. Multiple surgical team, because we were approaching the shift change. Estimated blood loss is high. I wouldn't say that we had a very high blood loss, but the amount of blood was disrupting. Changing the nursing staff during the procedure, which is exactly what happened, and the incorrect sponge count. What are some of the things that we can do to prevent this? Obviously, the counting of the sponge and instrument has to be done in a proper way. So, for example, in our case, they should have been paying attention to the marking on the sponges. Whenever we introduce a sponge in laparoscopic surgery or even open surgery, we have to witness the removal, and we cannot just assume that this was removed. This has to be documented by direct visualization. Intraoperative X-ray screening is not really very helpful, but some facilities use routine post-op high-resolution X-ray surveillance, particularly in high-risk surgery, long cases, estimated blood loss that's pretty high, etc. Now, when it comes to bariatric surgery, I'm one of the advocates of routine gastrograph and swallows on patients, and mostly to look at the shape of the sleeve and to rule out any major problems. But one of the added things that we can do in the post-op barium swallow or gastric graft and swallow is alert the radiologist also to detect any foreign objects. So in conclusion, a retained foreign body is a serious life-threatening complication. It is rare. It should be a never event. We have to stay vigilant, follow all widely accepted steps in ensuring the retrieval of the foreign body. If a post-op contrast study is ordered, checking for a retained foreign body should be part of that study. And I thank you very much.
Okay, hi everyone. This is Hassan Jalamni from Amman, Jordan Istishari Hospital. I'm very privileged to be here with you tonight, and I'm presenting a morbidity case, which is a small bowel obstruction status post-revisional surgery post-Roux-en-Y gastric bypass. So this is actually a male patient who is 35-year-old. His current weight is 135 kilogram. The current BMI is 40 kilogram per meter square. This patient had Roux-en-Y gastric bypass surgery back in 2009. His starting BMI was 47, and his best BMI, his nadir level, was 29 kilogram per meter square. Actually, patient did very well in the first few years, and then he started to regain weight and lose control over the few kilograms every time he gained. And he also started to have heartburn, which responded initially to on-demand BBIs, but at the end he had to be on high-dose regular BBIs in order to improve his heartburn. So patient had a preoperative upper endoscopy, which showed a class A esophagitis with no hiatus hernia. The pouch length was okay. It was 8 centimeter long. The width was 5 centimeter, and the gastrojejunectomy was a bit dilated, measuring about 5 centimeter. There was also a candy cane measuring about 5 centimeter in length. Hemoglobin level was 12. And the serum iron was borderline with no hypoproteinemia or hypocalcemia. So actually, we had to go through the long way with this patient because he was covered by an international insurance company, which mandated to go through 6-month evaluation interval. Patient was evaluated by our dietitian and psychiatrist, but the outcome was very poor. Patient could not sustain any weight he lost. So I counseled him about the 2 surgical options we have. We have a staged reversal with hiatus repair and then SADIAS procedure. That was the first option. And the second option was pouch resizing with hiatus repair and roux limb distalization to 200. Patient elected to go for the second option because probably he had concern that the insurance company wouldn't be covering his multiple procedures. So to the OR after the routine preparation, the magnitude of adhesions not the usual one that we usually have in original cases. I had to take 90 minutes in order to come up with the understandable anatomy. And actually, I could not localize precisely the trijunction between the 3 limbs because there was such an amalgamated small bowel matted mass, which I could not be very sure which limb was which. So at this point, I decided not to go further with dissection and probably inflicting more iatrogenic injuries to those fragile small bowel loops. And I decided to measure the distance between the ileocecal valve and to the area where I thought it was the trijunction. And for my surprise, this common channel limb length was only 250 centimeters. So I realized that I cannot offer this patient any more malabsorptive capacity. So I decided to abort the procedure without doing any further unneeded dissection of the small bowel or doing any job to the supramesocolic compartment like resizing the pouch or refashioning the gastrojejunectomy, because this patient would still probably ask for the other option that I offered him in the beginning, which was reversal. So I elected not to mess with the pouch in order to make the life of the second surgeon easier. Short clip showing the anatomy. like I told you, it took me 90 minutes to come up with this view. That was the rule limb, and this is the rule limb. You can see it's coming here through this matted small bowel mass and traversing through the mesentery. This is the, let me see, the afferent part of the rule limb coming to this area with very bizarre shape, W-plastic enterostomy. I don't know, and I still don't know what was the purpose of this W-plasty. I think this patient, maybe he had a distalization procedure that he didn't tell me about, or the first surgeon had difficult time in the first surgery, like probably he confused the limbs and then he had to do more resection and anastomosis to correct the anatomy. Patient did very well after this procedure, and he was sent home. 1 week later, patient presented with severe upper abdominal pain and bilious vomiting. CT was done and showed dilated native stomach and biliopancreatic limb. I tried conservative management, but failed, so I took the patient back to OR. Again, I started with the diagnostic lab, but it was very difficult. The small bowel loops were massively dilated and I could not sustain my fee, so I converted to laparotomy. Again, I found a dilated biliopancreatic limb with evidence of long-standing internal hernia. The thing that I suspected in the first surgery that didn't go further with dissection because it was obviously going to be a very difficult sort of dissection, but the rule limb was herniating through mesenteric defect between the biliopancreatic limb and the common channel, and in the distal part of the rule limb there was this bizarre shape of the W-plasty thing, and then it goes up again and comes out of the same defect to meet the biliopancreatic limb and constitute the common channel. So I dissected the hernia and all adhesions. I took the bowel back to its normal anatomy and orientation. And although the trijunction was obviously patent, I checked that with a suction tip, but I elected to refresh the anastomosis because it didn't look to me very healthy. It was a site of severe adhesions before. And although I didn't do anything in the first surgery, but patient got intestinal obstruction, and my explanation for that is that it was working for him with kinked small bowel for a long-standing time. It was working for him. When I put everything back to normal, it seems that a critical new obstruction happened and caused this small bowel obstruction. So I wanted to make sure that I wouldn't go out with or leaving behind stenosed part of this trijunction area. And the second question that I had to answer in the surgery is, should I use the same old limb length? And yes, I used the same old limb length because I thought about increasing the biliopancreatic limb length to give the patient more malabsorptive procedure. But since the patient had a reflux, I was afraid actually to add injury to the insult because that might be threatening a new bile reflux in the setting of a previous acid reflux. This is the operative view of the second procedure. So this is, as you can see, this is the rule limb. It's coming here through this mesentery defect, and this is the mesentery of the biliopancreatic limb. The rule limb, as you can see here, is coming down through the defect, and this is the bizarre thing here in the distal row, which I still don't know what was the purpose of that. And as you can see, the rule limb is continuing its way here to come back again through the same defect and then to meet the biliopancreatic limb here, you can see, and form the common channel. And this is the view after I reduce the hernia or the root limb through the defect. As you can see here, everything is coming back to its normal orientation. And now this is the final view with the root limb with the W plus sitting here. And this is the biliopancreatic limb. This is the common channel. Now the trijunction is understandable. I closed the mesenteric defect and then concluded the procedure. Finally, this is a diagram showing the exact anatomy of the internal hernia. As you can see here, this is the root limb, which was 150 centimeter long. The biliopancreatic limb was 50, not 150 like it is shown in the diagram, 50 centimeters. On channel, when I measured it in the open approach, it was only 200 centimeters. The total small bowel length here is only 400 centimeters. So I strongly believe that an incidence happened in the first surgery that made the surgeon resect part of the small bowel, and probably this is the site of the small bowel he resected. Patient was not informed about that. He didn't present any operative report, but at the end of the day, I guess that we fixed this very long-standing, although it was asymptomatic and became symptomatic after my first intervention, but we had to fix this by closing the mesenteric defect. Final slide here are some questions. How different would you have done that? Would you have proceeded with dissecting the herniating bowel when you knew that common channel limb is 250 centimeters? I'm talking about the first surgery. Second question is, would you have repaired the hiatus, reside the pouch and the candy cane after decision had been made to stop dissecting the herniating bowel? I'm still talking about the first surgery. And the last question is, in the second surgery, would you have changed the limb's length? Thank you very much.
Thank you very much for having me as part of this virtual IFSO MENAC Congress, and special thanks to Dr. Safadi for involving me in this M&M in bariatric surgery group talk. I'm presenting a case of severe gastroesophageal reflux disease with a gastric band and a large hiatus hernia. Removal, repair, and revision to a Roux-en-Y. Too much. This is my case mix for the IFSO disclosure. This case is a case that has been performed some time back, and you'll be able to see from the videos and the instruments that they're not the newest because it has been a while back, but I'm presenting it because I feel there's something to learn in this case for myself and everyone, particularly the juniors. It's a 53-year-old female patient who has had a gastric band in our center 4 years earlier. She started developing symptoms of gastroesophageal reflux disease and vomiting, and they were actually quite progressive. We did all the necessary investigations in the form of a barium, CT, and an OGD, and they all showed a large paraesophageal hernia, and that the band was lying at the hiatus, that the findings of the OGD showed esophagitis too. So I will show you the initial surgery that we did. So I've edited the video in order for me to stick to time. Removing the gastric band as we do, using a combination of hook diathermy initially on the capsule, ultrasonic dissection to remove the very thick and cicatrized gastric band. And you can instantly see at the left crus here the paraesophageal hernia. It was actually quite sizable in this case. And we started slowly dissecting the hiatus. You can see the pleural reflection was just evident there. And you can also see that stomach is still way up there and resistant to come down. A bit of pulling, perhaps a bit too aggressive for my liking when I watch this video. I wouldn't do it like this now, but this is what I did then. And further dissection up, the lung is nicely seen, the pleura is still preserved, and a very thick and cicatrized sac is going to come into view now. It has been obviously a hiatus hernia for some time. I tried to go back to the initial video of the gastric band, which I didn't do, to try to see whether we may have missed the hiatus hernia at that stage, but it was very difficult for me to gather at the time. Closing the hiatus with interrupted ethibond stitches, 2 posterior, 1 anterior, just to make it look a bit pretty. And then just sizing the hiatal defect, because I, at this stage, used a bovine pericardial Veritas mesh. Now, you can see that I used tackers that I wouldn't normally use these days. I stitch if I use a mesh, and I actually hardly ever use a mesh. I use falciform flap. You can see that I'm not going to bore you with the rest of the bypass, but you can see that when I placed my stapler there, I had doubts. I liked watching this bit of the operation because at that stage I had doubts. Perhaps I should have stopped. Well, I mean, retrospect is a very useful thing, and I should have, but I carried on and did the Roux-en-Y gastric bypass with a vertical pouch, as I normally do. I leak tested it, and I just want to show this because it's very important for the next video. Under pressure, it withstained and it did well. This is the classical kind of, and I had good opposition of tissue, and I wasn't really worried at this stage, but I was initially avoiding the gastric band capsule that I have capsulotomized and have good opposition of kind of good looking tissue everywhere. So I will now go back to my presentation. So day 1 and day 2 post-op, the patient was quite well, stable, tolerant to her oral fluids. I wasn't concerned at all about her. Her biochemical blood tests that we do on day 1 were all quite within acceptable range. The CRP is high, but that's acceptable. However, on day 3, she developed acute left shoulder pain, became tachycardic, a bit of temperature, and the CRP was a number that I do not think I've seen in bariatric surgery ever after this case, which is a learning point. So, of course, scanned her, and we saw what we all don't want to see, and it was quite clear that there is a big leak with a big, this is why she had her shoulder pain. You can kind of quite clearly see it. So going back to my next operation video, which again, I will, I've done my best to try to not bore you with a very detailed video, but you can see that you go back in and there is this large left subphrenic abscess. The tissues look so mucky, and it's only day 3, so it's not like what you want to see at all. Pus coming everywhere, tissue's very friable. It's basically a big mess. And I sucked all the pus out, and you leak test, and you can see the bubbles quite clearly. At this stage, it was very evident that the bubbles were coming from the staple line. I know that there will be criticism for stitching, but it's just brand new, it's fresh, and it's a tiny bit of the staple line. So you're never right in these cases, and you're never really wrong. Again, it's just the staple line on the side, another ethibond stitch in an interrupted manner. I'm not pulling too hard, just hugging the tissues together. And then I will elect to put some fibrin glue, and I leak test and leak test again. Again, some people would say just leave it drain and leave. This is my fibrin glue. We left it, and we managed to get away with this. I'm going to leave my thank you slide with my email, but I think that when I used the name on the slide, I said it's too much. It was too much, because I think we managed to do quite a lot in the first case, and perhaps we would have stopped at just reducing the hiatus, removing the gastric band, and leaving things to come back in another day. Again, with the benefit of hindsight, that was the right thing to do, and that's what I generally do now. As I said, this procedure was done a number of years ago, but I just felt it would be a useful one for the morbidity and mortality meeting that I have been invited to by Dr. Safadi and the IFSO MENAC Society, which I am honored to be a part of. Thank you very much for having me.
Great. Well, thank you very much for all these interesting cases. We have a lot of questions already that are coming in. Raul, you want to start the discussion? What do you think about these cases? I think you're muted, Raul.
I was muted by the organizer. I don't know if they unmuted me.
Yes, we can hear you now.
Okay, great. Well, the cases are very colorful, and I don't think we could have the whole day to discuss what to do on each case. Probably the case that I'd like to comment is more than anything the one of a retained sponge or retained object. We take this very seriously at the Cleveland Clinic, and we have what we call the Universal Protocol. And I'm part of the Universal Protocol Enterprise team. The Universal Protocol is a checklist that we implement for every intervention. That could be a surgical case, could be an endoscopy, or it could be the simple placement of a chest tube in the ICU. The Universal Protocol has different steps. First is the sign-in. And the sign-in, the surgeon, the nurse, the anesthetist, everyone has to be together, and we verify that this is the right patient, the name, the birth date. We go over the consent form, make sure that the consent form was properly written and properly signed. We go over the antibiotics. We go over the right side, because a very common problem in high volume centers is wrong side surgery or wrong side intervention. The second part of the Universal Protocol is a timeout. So before you do any kind of incision or passing a scope, the nurse will call the timeout, and she will read again to everyone the name of the patient, what is going to be done, what's the antibiotics, et cetera, et cetera, et cetera. What we have now implemented new is the count timeout. So at the end of the operation, before the surgeon is ready to close, or to remove the trocars, or to remove the scope, everyone has to stop. There is no music, there is no talking, and the nurses count all the tools. And that includes also laparoscopy, because in laparoscopy, as you know, sometimes you put a sponge to create hemostasis, or you take out a band and you leave a piece of the band in there that you say, I'm going to take it at the end. Sometimes could be a specimen. You know, you do a resection of the stomach, you take out the gallbladder, and you do another little thing. You put everything in the left upper quadrant abdomen. You want to make sure that everything that you put in comes out. So this timeout for the count, it's something new that we have implemented. And obviously the reason is because of what was said before by the presenter, by Bassem, that this is a serious problem and it happens. And since we, as an enterprise, have so many hospitals worldwide, we want to make sure that this doesn't happen. And last but not least, before the patient gets woken up, we have the sign off. So sign in, time out, count, time out, and then the sign off. And in the sign off, the surgeon and the nurse go over everything. Was the count correct? Was the specimen correct? Is the wound clean contaminated? Was the procedure done as consented? And once all that is done, they wake up the patient. Because once the patient is extubated, if something went wrong, we have what we call in America a code 15. A code 15 means that you have 15 days to communicate to the medical board that something went wrong. And the medical board comes very hard on you. 50 hours of community service, money to be paid, including suspending your license. So this is taken very seriously, and what Bassem Safari taught us was excellent. And that is my contribution to this discussion.
I thought this would be an interesting case to present, and for that, I would like to put a poll, if that's okay with you guys. And please, all the participants who are attending the session, please answer the question is, have you ever had in your surgical career a retained foreign body object? And this is, like Dr. Rosenthal suggested, not only limited to a gauze, it could be anything. It could be part of a specimen or a specimen. It could be an instrument, anything. And I would also like to welcome the other panelists and the speakers to comment on this, and we can move on to the next topic. Sharif, you had something to say?
Yes. I actually have a case which is quite similar. It wasn't in bariatric surgery, and we followed what Raoul did. I operate in London as part of the NHS in Imperial College, and we followed exactly what Raoul did to the last letter. We had what we call the team huddle to start with. We had the sign in, we had the sign out, and the end bit, which we call pause for the gauze, where we stop and count the gauzes. It has to be done by the most senior surgeon, and everything was perfect. And unfortunately, the patient presented back. It was a laparoscopic appendix converted to open right hemicolectomy that was started out by our registrar or the senior fellow, and ended up being converted to open. And I was called in. I had started my shift at 8 p.m., which is again a shift change from one consultant to another. What happened is the patient presented back 3 weeks later, and the patient had a retained specimen. We went back, the swab count was
seemed to have
correctly, and I had signed it. And I would never sign it if I did not count the gauze myself. And unfortunately, what we missed on that day.
Sorry, Sharif, we're losing you.
Can you hear me and see me now?
You said what you've retained, and then it got cut off.
And you now can see me, or am I still having slow signal?
We can hear you. So what did you lose in the abdomen?
We found that it was at the time that they were doing the laparoscopy, they put a specimen, the bird bag, the specimen bag. And this was because there was tissues being fragmented and fecalate, and they put that inside the bag, which was forgotten. And it's not part of the sign in or the sign out or the pause for the gauze. And it was actually very well reported publicly in the UK. Unfortunately, we didn't cover ourselves in glory. And we had to change our sign in and sign out to include something that says, or any other objects that may have been used during the surgery. So even though we did cover everything, we still managed to forget something inside.
Yeah, this is a very common problem. As you can see from the poll, our surgeons, 41% of them had a retained foreign object. That's a pretty high number. Can we move to the next question? So of the 41% who answered, has this resulted in a major morbidity or mortality, something minor or nothing at all, a lawsuit, or perhaps a combination of 1 and 3 or 2 and 3? And I think it's not only that these result in major morbidity and mortality, but they invariably end up in court, and the surgeon has no defense whatsoever. So that's a big problem. So one of the questions that was asked is the value of routine gastrograph and swallows. Do you guys do routine swallow studies on your post-bariatric patients or no? Ramesh, do you do routine gastrograph and swallows on your sleeves or bypasses?
Yes, we do it usually in the second day one, usually post-bariatric surgery, especially in sleeve gastrectomy, and not all the time with the bypass. Only in cases, query cases that possible leak might happen, we do it the second day. But usually all cases with the sleeve gastrectomy, we do it.
Great. So the poll results came in. 22% resulted in major morbidity and mortality, and luckily the vast majority, or the majority, not the vast, the majority did not result in anything major. In this part of the world, in the MENA region, I don't think lawsuits are a way to resolve conflict, so that's probably why the issue of lawsuit is not that common. So, Dr. Bukhari, we have a question from Dr. Ahmed Bashir. He said, usually patients with VBD present with severe reflux and weight regain. Why would you convert them to a sleeve? And what are the necessary studies you perform before that? I think you are muted, Dr. Bukhari. We still cannot hear you, Walid.
So mute.
He might have been muted by the organizer.
He's the organizer. That's okay. So we can, I guess, move on. There's a question to Dr. Jalamni. Looking back, this is from Dr. Ahmed Bashir. Looking back, would you have resected that complex in the first operation and re-anastomosed the limbs, as this may have contributed to the patient's severe reflux symptoms? And perhaps if you allow me, Hassan, maybe I can ask the panelists or the discussants, who would have done what Hassan did and abort, and who would have continued? I personally would have opted to do what you did, especially after measuring only 250 centimeters of a common channel. I would have done the same, just stitched up the enterotomy and closed. I'm curious to see what other discussants would have done.
Yeah.
Maybe start with Raul.
Dr. Bukhari, now we were listening to you. Your microphone is open, so you can talk if you want.
I don't want to interrupt Dr. Safadi.
Yeah. So maybe we can ask you that question and then you can answer the first question. Good to have you back.
Thank you. Should I go on?
Yes, please.
Yeah. Okay. Of course, as you've seen, it was at the beginning of the experience where we have used simple sharp dissection with monopolar scissors. We don't do that anymore, but we have seen that doing a sleeve after an operation like the VBG, the conventional VBG, when you have exposed the patient for the psychological assessment in eating disorders, when you have educated the patient on nutritional by the nutritionist, when you have when the patient was assessed from the endocrine point of view, we have very good results with the sleeve. I think partly because we remove a major part of the stomach that contains a lot of the ghrelin producing cells, and that helps in curbing down their hunger. Still, we have seen weight regain in patients post-sleep. So I think a very major attention should be given to the psychological assessment in eating disorder and management and I stopped doing those surgeries immediately. They have to go through a course. Sometimes it takes up to 6 months to do them. But what I wanted to say, that it is a feasible procedure. It is not impossible, though it's difficult. And you have to give a very special attention to the vascularity of the wall of the stomach when you attempt that.
And what about the issue of reflux? Since patients with VBT have reflux disease.
Yes. This is the point that I always stress, and we're carrying out a study for over 1,200 cases, which we have done, as Dr. Hassan Hussein Jalama from Jordan have seen. We stress a fact that we always check for the hiatus hernia preoperatively and the reflux with or without symptomatology. One. Secondly, so chloroplasty, when it's needed, we do it, and we do 1/3 and 2/3 chloroplasty. I mean the diameter of the chloroplasty itself. The second thing, we fix 2/3 of the stomach to the pancreatic capsule ligament, which is a very strong ligament, and that helps a major role in reducing a lot of people just take the greater omentum. The greater omentum is a mobile organ. The ligament is not. And you could see, I shown in my films, where you put a tight tube, the 36 French tube, in and out, the stomach doesn't move. When we used to do this using the greater omentum, you could see the stomach, when we're pulling the tube out, is being pulled partly in the thorax. So I think the technique of doing the sleeve also plays a role in the episode of post-sleeve gastrectomy reflux. We have a very low rate of reflux since we started doing that, and we're making we have done a study, a retrospective study. We're just collecting the full data up to 5 years post-sleeve gastrectomy for over 1,200 cases, and we're going to show that maybe in 6 months' time.
Great. Regarding Dr. Jalami's case, would you have continued, or would he have aborted like he did?
I think, as I said in my conclusion, it's very important to have a full visualization of the field. You have, in such a difficult case, and it's a very difficult case, I must congratulate Dr. Hassan. I don't think he made a wrong decision or even a doubtful decision, but in my situation, I would make sure that I have the full length of the stomach. I'll make sure that any unclear question in the prior surgery has to be either identified through a good operative detailed report from the previous surgeon, or through a preoperative full investigation. And I would consent the patient for either way. I would consent him for the worst case scenario. I would not just go in and surprise the patient. So the patient has to consent for the worst. But putting in mind that Hassan did not have a full visualization of the field, and there was no full counting of the bowel from different aspects of it, I think I would have done the same.
Well, in the first surgery, actually, Prof. Bukhari, I could see that I had a full visualization of the common channel, which I was sure it was only 250 centimeters. So that the question was at that point, should I pursue my dissection and visualize everything, and probably doing nothing, because the common channel is only 250 centimeters. The patient is asymptomatic before the surgery. He doesn't have any obstructive symptoms. The only symptoms he had were only reflex symptoms. So that was the point which changed my mind. If I did dissected the herniating bowel and then get it back to its normal geometry, what could I have done for that patient? He has only 250 centimeter common channel. I cannot do any more distalization. And the second thing, if I
elected to increase the pilopancreatic limb length on the count of the rule limb, which was 150 centimeter. Could that have caused more reflux? Patient was already having reflux. I was planning to do a hiatus job for him. So at that point, when I realized that I will not do any major step for the purpose that the patient was asking for, which is a weight loss, then I elected to abort the procedure. He was asymptomatic. The problem is that why did that happen? I didn't do any resection. I didn't change any limb length, and then patient came with obstruction. I would mimic that to dealing with incisional hernia when the loops in the sac are not obstructed, and when you start dissecting those loops, you have to be very sure that you are doing a full job. So after I removed the adhesions and got the small bowel from where it was adherent to the anterior abdominal wall, probably a kinking was there, but it was open. Putting everything back to normal, it was not normal, but what I thought is normal probably had made another critical kinking that caused the obstruction. The field was very difficult in the second surgery. When I was there, he already had obstruction. The small bowel were very dilated. So, and to be honest with you, I was probably angry of the patient because I had the feeling that he had the distalization procedure that he didn't tell me about. That procedure was 10 years ago. He didn't present any information to me, and he put himself and myself to rest. So I wasn't very keen to spend more time with this obstructed field. So I elected to do that mini laparotomy. And with that mini laparotomy, it took me also 30 minutes with open approach to release all adhesions and know the exact malformation that were there.
Can I respond, Dr. Safadi? Can I respond?
Yes,
yes, please, Dr. Bukhari.
Yes, I think, as I said, in your shoes, I might have done the same, but as a principle, when I go in a revisional surgical case, I will detail the detail. I will have to know about everything. I will dissect. I will count. I will count the ileocecal junction. I will check every fold. I will check the mesenteries. I will check the Patterson space. I will check the hiatus, especially he has a reflux there. I might have done the same, but this is the way, this is my approach, especially in a second or a third operation, a revisional operation.
And the problem, Prof, is that unfortunately we don't have any modality to measure the small bowel length. We may do CT scan, volumeter, everything to have a look on the gastrojejunostomy, but having no pre-operative, post-operative report, I had no tool pre-operatively to be sure that this patient probably had another procedure or a complication in the first procedure that he was not aware of.
I'm talking about intraoperatively, when I've been there. Pre-operatively, I understand what you said, but as long as I am inside the field and it's a revisional surgery, second or third time, I don't know, I have to really map out the whole situation.
I have a question for Ramiz. Dr. Sharif presented his case and raised the question is whether he should have done it in 2 stages or 1 stage. When you're confronted with a patient similar with a hiatus hernia, reflux after band removal, do you prefer to do the gastric bypass in 1 stage or 2 stages? And do you think
yes,
that's
definitely
the leak?
Yes, definitely in 1 stage. But what happened in that case, he kept a piece of stomach. The wall was so ugly due to the band, and all of us know that the band created a lot of fibrosis at that area. And he did a side-to-side anastomosis between the remnant of the stomach and the jejunum. And what happened is poor healing at that area due to a lot of fibrous tissue at that area. So what happened is leak. And I think if he transect the esophagus and do esophageojejunostomy with circular stapler, it would be more safe And I think it could be done in one stage, esophageal rather than gastrojejunostomy at area with poor healing due to band and fibrosis.
Perhaps I looked at the video and I didn't really see any major technical problems. I personally prefer to do hand-sewn anastomosis in redo cases. I don't know what you guys think.
I'm not talking about technical problem. Usually, this anastomosis at that area usually it won't be perfect. But if he do it esophageal with circular stapler, it's more safe. You go to virgin area rather than to go with a diseased, let us to say diseased area.
I guess we have a few more minutes. Let me run through the questions. Dr. Bukhari, a question from Dr. Hussein Shamish. When you do a Balthazar procedure or a gastrectomy in the presence of a gastrobronchial fistula, do you worry about hypercapnia, or do you notice that the anesthetist is worrying about hypercapnia in those cases?
Well, usually the anesthetists that are involved with us are, experienced, especially in those patients, pulmonology and anesthesia. And hypercapnia we haven't seen happening. I've dealt with more than 13 or 14 cases of gastropleural and gastropleurobronchial fistulas. Actually, in a matter of fact, a couple of weeks ago, we had one long case of that sort. As long as you remove the primary cause that is unrepairable, you cannot repair a gastropleural fistula by primary repairing a chronic fistula in the stomach. You have to remove the primary leak area, which is the leaked stomach, either partial, if you want later on to do something else with it, or a near total gastrectomy with an esophagojejunostomy, and dealing with the subsequent complication of the gastropleural or gastrobronchial fistula through thoracoscopy, through pleurodesis, through, if there was no collection there, through cleaning and filling it up with fibrine glue. And we have done all those, and seriously, we had no trouble whatsoever. In 3 cases, we had to do pleurodesis, and we had to leave thoracic underwater seal drains.
We have a question from Dr. Bashir. Do you put a gastrostomy tube in redo cases when you have a leak at the gastrojejunostomy? Sharif, why didn't you put a gastrostomy tube or a feeding jejunostomy in this patient?
The question is for whom?
I guess it was to Dr. Hakim, but you can answer that, Dr. Bukhari.
No. I've talked so much. We'd like to hear somebody's.
Walid, it looks like we've lost Sharif, probably from internet connection.
Well, I would like to hear from Raul about that, really.
Well, I think gastrostomies are always a good safety approach, if you're unsure, because not only it is a diagnostic tool, it helps you to decompress the GI tract. It helps you to do diagnosis if there is any kind of post-op distal complication. It helps you to feed the patient if there is any problem with your proximal anastomosis. So I am very open-minded in using gastrostomies. I think that you would rather err in doing too many than doing too little. Another thing I want to comment is one of the discussions was to do preoperatively a CT angio to verify the patency of the left gastric artery. What we are doing now routinely is our own intraoperative angiogram with fluorescent imaging. If there is any message I can give to the whole region that you should really look very careful into and start using it, because it's not only available, but it's also not costly, is to use ICG fluorescent cholangiogram, ICG fluorescent angiogram intraoperatively. The fact that the left gastric artery shows up preoperatively in the CT angio doesn't mean that it is going to give you good blood supply to the part of the stomach you're going to be doing an anastomosis. And it doesn't necessarily mean that after you do all your dissection to create a new anastomosis that you did not divide it or occlude it. So reoperative surgery pays a price. The complications, the leaks go in our hands from 0.5% to 10, 11%. So I think that I published our data. So this is not just talking, it's published in Obesity Surgery. And Kelvin Higa has similar numbers. When you reoperate, the leaks dramatically go significantly up. So I think that fluorescent imaging angiogram will help us to prevent this from happening, because one of the main reasons why we have leaks is because there is poor tissue blood supply, and we are putting together things that are not gonna last. So I'm going to stop here and let other people participate and contribute. Thank you.
Thank you very much, Raul. I think we're going to have to close the session. I would like to thank all these speakers and the panelists, and I would like to take this opportunity to thank Dr. Walid Bukhari and Dr. Mirza for really a fantastic session. And I would like to thank IFSO, Manuela, Claudia, and Stefania for their great work. And Dr. Mirza is going to do the closing remarks. Thank you again.
Hello, everybody. I would like to thank you for all your effort, and everybody shared us in this meeting. I think you can see my slide, right?
Yes.
Yes, you hear me? So on behalf of Scientific and Organizing Committee, thank you to all of faculty members and speakers and attendees. This is from all board and all the scientific committee and organizing. They are sending you here their appreciation and thank you. And thanks also to Ethicon and also Bariatric Solution and Novo Nordics. I want to show you our registry 970 coming from 73 different countries, and these are the countries where they are coming from, which is very nice, showing that how much the people interested to attend such a meeting, even it is virtual. And I know that they are missing seeing each other. Regarding the upcoming meeting, we hope that it will be the second IFSO MENAC meeting, and fourth Pan-Arab, and also Saudi Society and GOS. I hope that it will be in February 2021, because we have a promise by government that everything will be fine by 1st of January, and also the world will be free. Before just to say goodbye, I would like to ask Dr. Walid to give us a conclusion about this Congress of the 2 days, and also to remind all the audience to stay with us for the symposia of Novo Nordics about non-surgical modalities of treating patients, which is a medical treatment, and it is very nice subject, and I hope they will attend. And I will leave the floor to Dr. Walid, the president of this Congress, and I will thank you again, all of you. Thank you.
Thank you, Dr. Khalid. To say the least, it was a very well-organized meeting. It was very interesting. Now we know for a fact that bariatric surgery is the method of choice for dealing with morbid obesity and its comorbidities. The importance of comprehensive approach for treating obesity has been established and reconstituted and re-stressed in this meeting. We have seen in this meeting that there is no single standardized method of treating the serious complication of bariatric surgery procedure, which is the weight regain. In a matter of fact, the other complications that happens are technicalities that are dealt with in one way or another. But the weight regain is a serious and a major problem as a serious complication of any bariatric procedure, primary bariatric procedure. So at the end of the day, we did not agree about a standardized method in dealing with this problem and this issue. But we have to standardize our methods to the best approach to treat the difficult problem of weight regain. Revisional surgery on its own, in today's trends in advanced bariatric center of excellence, should be only done. So it has to be in a well expert hands, and it has to be done in a center of excellence where all the assisting departments can contribute to the safety of the procedure and safety of the patient. Because it's a high-risk approach that carries a lot of morbidities and mortalities even, as we have seen, and a lot of people talked about in this meeting, and that has to be really taken care of to progress and improve the outcome of such a difficult approach. And I would like to extend a welcoming invitation to our meeting in Khobar, hopefully sometime in February, maybe 21, 22nd, 23rd. We will keep you updated depending on the ongoing pandemic, that I hope everyone stays safe and healthy, and we'll see everyone in every upcoming webinar and Zoom meeting. Thank you again, Dr. Khalid, and I leave the last word for you.
Thank you. Thank you, everybody. And again, we appreciate your contribution in this meeting, and we would wait for you for the last session of this today, which is a symposium from Novo Nordisk. We will wait for you. Maybe it will take a few minutes to start. Thank you, everybody. Thank you.
The Novo Nordisk Symposium can now start.
Dr. Mirza, please unmute yourself. Thank you.
Okay.
Okay now.
Okay. So good evening, everybody, or good morning, up to your location in this world. This is the beauty of virtual meeting. I would like to welcome you to this session. I'm Dr. Khalid Mirza, consultant bariatric surgery and president of IFSO MENAC chapter, and also the chairman of the Bariatric Surgery Center in the Dammam Medical Complex, and vice president of Saudi Arabian Society of Bariatric and Orthopedic Surgery. we would like to talk about the obesity is one of the 5 most important health concerns all over the world. Definition by WHO, obesity is an abnormal excessive fat accumulation that may impair health. Body mass index is the simple index of weight for height that is used to classify obesity in adult BMI more than or equal 30 kilogram per square meter. So overweight and obesity worldwide, it's getting more and more, and we have this study in 2016, and we are sure that it is getting higher, overweight and obesity and healthy weight. So we can find the number all over the world increase. Here, obesity, we can find 1 in 3 in Saudi has obesity, and 2 out of 3 Saudi has overweight, BMI equal to 25 or more, and 2 out in 3 Saudi recognize obesity as a disease. So it is also in our country and this area, Saudi Arabia, and also in the MENA area, it is really a big problem and affecting all the community. If you ask me why, because we are almost the same culture, the same habit, and the same type of food, which is very nice and attractive for tourists also to come and eat. And it is the Middle East. That means we have all type of food from East and West. So available and with the affordable price. This is why, and the new life in this area becoming, especially in young generation, the obesity getting more. So the obesity is recognized as a disease, not a very good level. So most of the people, they think it is just a case, and they don't recognize it as a very serious disease. I will leave the floor before I continue to my colleague, Dr. Issam Bhatia. He's a consultant bariatric surgery, and he's working in one of the bariatric surgery center in the Saudi Arabia. He's going to start his lecture, and then I will continue after him. Dr. Issam. Yes, you unmute yourself, Issam. We cannot hear you.
Dr. Mirza, maybe while Dr. Bhatia find a solution for his microphone, we can launch the 2 presentations, if you agree.
Okay, so he will start and I will continue after him. Yes. Or
Fine.
you want me to start?
We will see the 2 talks now.
Yes.
Good evening, everyone. It's a pleasure to have this presentation with my colleague, Dr. Khalid Mirza, and it's a pleasure for me to meet our colleague and to participate in such meeting. I will just talk briefly about the obesity management challenges and why those challenges are happening. I am Dr. Issam Bhatia, Consultant General Surgery at Al-Noor Specialist Hospital. So we know that obesity is a complex and it's a very progressive multifactorial condition. There is too much about the equation between energy intake and energy expenditure. We have a lot of talk about there is too much of the hedonic input, especially regard that people with the pleasure of eating and the food eating. And also there is environmental, especially regard the inactive lifestyle, the psychosocial factor. So there is too many factors playing role. We have a lot of things. We have the adipose tissue, we have the pancreas, we have the gut, and these are regard the organs that playing a major role in obesity. Plus that there is some genetic factor. And nowadays with most of the chronic disease, a lot of people, they are taking a lot of medications. So obesity has been recognized as a chronic progressive disease, and it has been endorsed by all societies all over the world. So if we start with the World Obesity Federation, they mention it that it is a chronic relapsing progressive disease, and they emphasize the need of immediate action. If we talk about the American Medical Association, they recognize that again, obesity and overweight as a chronic medical condition. If we talk about the US Food and Drug Administration, obesity is a chronic relapsing health risk that defined by excess body fat. Canadian Medical Association, European Association, it has been shown that a progressive disease impacts severely on individual society. European Medicine Agency, obesity is recognized as a chronic clinical condition. So there is no rule that we are not treating a chronic illness, that it has a very complex root. We have a lot of factors playing in the cause of this obesity. We start with environment. Nowadays, a lot of environment. The eating culture, the application and the mobile app that you can order whatever you want and you can get it while you are watching your TV. The transportation, we are almost barely that we are mobilized and moving all around. The computer games, our kids, they are staying in front of the games and the monitors for hours and hours, while they should already enjoy playing in the backyard or in the ground. A lot of the social media workplaces, it has been limited spaces and there is no open spaces. A lot of other, if we take the other part with the genetic things, there is a lot of inflammation, medication, the way cycling, and even the issue of the brain and how the brain deal with this. A lot of more of a stress during our life nowadays. There is a lot of issue about the sleeping and the sleeping habits. So what are the obesity treatment options that we can offer? There are three primary treatment options, and those are, let's talk about the cornerstone of obesity treatment. The first one is lifestyle intervention. If you are not going to change your lifestyle intervention by changing your health, eating healthy food, doing some physical activity and behavioral therapy, you will not go anywhere else. The second thing is the pharmacotherapy. There is a lot of medication that's been approved and it's different from one country to another, which one is being approved by the FDA in that country. For example, in our Saudi Arabia, we will talk about that. And finally is bariatric surgery. And please take care of that regard increase the disease and the severity with the arrow. That's mean it is complementary, and those with this style, it is not individualized. That means not each one only will work alone. We can combine those three options and those primary treatment options, and this is what we are going to talk about. So one treatment alone, it might not be enough. If you do just only surgery or doing this or that, or just only giving a low carb diet, but if you combine or if you find a modality that can combine and complementary each other, will make a lot of changes. So the weight loss is varied widely among the patient. If we took the patient who is only with the diet and the percentage of the patient that they improve only with the diet, and then we compare them with the patient that with the drug alone, and then with the patient that with some special devices like a duodenal leaner, and the patient with the surgery and the percentage of their weight loss. We know that the maximum of that can be reached, but if we combine all of these things together, we will have more efficient to fight with the obesity. Obesity and its care, it's a battle of force that influence the fat mass set point. So if we draw this line, as we just mentioned earlier, with all these exposures, that abnormal dietary, unhealthy muscle, sleep deprivation, stress, and etc., all of this will be, if you try to have healthy diet, regular physical activity, more and better sleep with the stress reduction and stable eating, you will maintain with this and give little bit more with some medication. And if you do with the surgery, so all of that effort, we are trying as much as possible to keep this body fat mass set point. And if you get it lower, that would be much better. So no question about the sustained bariatric surgery weight loss over the last 20 years. And we all know the famous study from JAMA, the Swiss study regard the comparison, and we can see here that the main weight loss, it has been recognized and sustained, especially for the gastric bypass. So it is not anymore questionable. But if we compare it and we start to talk about the comparison at the percentage of the patient with surgical group and compare between the two major groups of weight loss between Roux-en-Y gastric bypass and sleeve gastrectomy as one of the most common procedures performed nowadays all over the world, we can see that the maximum or the percentage of weight loss that reach almost comparable to each other. So the fat mass set point and the post-operative weight regain, it's a major issue. A lot of people, they underwent surgery, Roux-en-Y or sleeve, but after a few years and with the time of the years, unfortunately, there is an environmental influence that we just mentioned, and it raised the bar a little bit for the body fat. But if you do the surgery, you will have a marked decline about that, and the influence of that in environmental, it will be less. So this is what we are looking for. So weight regain after bariatric surgery, it has been in the literature, and even if we are doing, as far we don't have the magic bullet for one single surgery that will do all or over the effort. Significant of about patient around 15 and sometimes reaching to 25% of patients within 2 to 5 years, they will have some sort of weight regain. The etiology of that, it is patient-specific factor or surgery-specific factor. And as listed here, the amount of physical activity, patient mental health, nutritional compliance, the follow-up, which is unfortunately a major issue, pre-operative variability, hormonal imbalance, support group, and even the surgery itself. We already now know that a lot of factors playing role, especially the dilatation of the gastrointestinal stoma. That's why we are doing the banded gastric bypass. And if there is gastrogastric fistula or the gastric pouch length, and the residual of the gastric volume, dilatation of the gastric sleeve, and if there is any retained fundus. So the rationale of the preoperative bariatric surgery preparation is especially recommended for the patient with the BMI more than 65. And those patients, if we do a pre-surgical weight loss, it should be mandatory to reduce the intra-abdominal volume and achieve operable in laparoscopic technique because of the difficulty. And this is proven with the study. For some individual, this is difficult to achieve with the diet and exercise alone. As such, the use of weight loss medication is the best option and considered a major cornerstone option that should be and it should be always people think about. So pre-operative weight loss, will improve this post-operative outcome. I know this is a debate, and a lot of people, they talking about it, that it's needed or not needed. But if we are talking about those kind of patients just mentioned in the slide earlier, who has a super morbid obese, each 1 kilogram, you are decreasing the comorbidity and the morbidity and the mortality for those patients. So as we can see here in this study, there is a greater post-operative weight loss. This is influenced on shorter of length of hospital stay and fewer the post-operative complications. So from this study, we can see that according to their use, they use the liraglutide, which been given for the patient, and it has been given, and in its help not even before surgery, even after surgery, it improved and increased the median weight loss for those patients. And from this study, we can see that the effect and how much increase that. Thank you. I will leave the rest for my colleague, Dr. Khalid, to present his cases and what he is going to show you on practical point of view.
Good afternoon again. I'm going to present my part, which is benefit of liraglutide pre and post-operative. If we think about pathophysiology of obesity, as you know, the obesity is multifactorial disease, and we have involving many mechanisms of the body to regulate the obesity, and including hormonal and neurological and behavioral. So as we say, it is not one cause or one pathology, etiology for the obesity. It includes several organs, and the mechanism of action of these organs is so complicated, integrated together, including all these hormones. So once it is multifactorial disease, so the treatment will be not a simple treatment, surgical treatment or medical treatment. It should be multidisciplinary team and management with multiple management with surgery and other adjuvant therapy. As you know, the cause of obesity, as we said, multifactorial, including behavior. So in bariatric surgery, we base on controlling hunger by restrictive procedure, in which we control hunger and we control calorie intake. While in malabsorptive procedure, we will have another added mechanism in which we are changing the anatomy of the gastrointestinal tract, in which we alter the other hormonal and neurological factor in the disease in pathophysiology. So when we do this in bariatric surgery, mainly with the malabsorptive, we will have more effect. So with restrictive, we are using one factor, while in malabsorptive, we are using restrictive and which alternating and changing the anatomy of the GI tract, which make more effective in weight loss and maintaining weight loss. And current, our situation, current target of anti-obesity medications, we have only 2 medications approved by Saudi FDA, which is as we know, liraglutide 3 milligram and orlistat. It is the only 2 medications approved in our country. How is the GLP work, which is a glucagon-like peptide 1 receptor agonist? It work in the center of appetite, regulating and controlling the appetite and hunger. You know, as most of these patients suffering from feeling hungry and unsatisfied. So this medication will control in this way. There is many studies done showing the effectiveness of this drug, like for example, the across the scale trials in which we use liraglutide with placebo, and we compare the excess weight 5% up to 10% according to the duration and the dose, which is the dose as we know, 3 milligram, and duration. So it is clearly there is a big difference between the placebo and the effectiveness of the drug among these patients. proportion of early response also, it's clearly we can see how the people and patients respond to liraglutide 33 milligram and almost up to 67.5% compared to non-respondent using a placebo. So it is another evidence of effectiveness of the drug in controlling the weight and diabetes. Mean weight loss percent from baseline to 2 weeks 56 of using this medication, it's clearly that 5% weight loss is higher with this medication, and 10% also is higher than placebo. So it is clearly the drug is very effective, but we have a problem with some of the complications. There is some side effect. I will not say complication, but side effect of the drug, mainly nausea and vomiting. But it's clearly from the studies that by time it will be controlled and patient can tolerate and can change a little bit of his behavior and attitude in using the diet. So we can, it is limited to few weeks, and most of the patients, they can tolerate it. Doses and administration is very important. It is escalating technique. So the dose escalation, it depends, starting from first week 0.6 for 1 week, and we increase it up to reach to the 3 milligram maintenance dose in the week 5. But some patients, they cannot tolerate in one of these weeks, so we advise them to go back for another week in the previous dose. We have to monitor the GI symptom for this patient, the tolerate, how the patient tolerate this medication, and we have to follow up. This patient, we cannot just give them the medicine and let them go. So we have to follow them up and try to help them to control their diet and overcome the side effect of these drugs, especially the nausea and vomiting. And if they cannot tolerate it, we can control by going back to the previous dose. But if the patient having severe symptoms and he cannot reach the continue, we can wait and reinvestigate, evaluate the patient. And also if the failure of the losing 5% of the baseline at 12 weeks on 3 milligram, we have to reevaluate the patient and look for the reason to stop the medication. In IFSO 2017, in this meeting, there is some studies showed that the effectiveness of this medication for weight loss preoperative. In preoperative surgery, we ask the patient to lose at least 10% of weight preoperative in bariatric surgery. So in this study shows that the effectiveness of this medication to control, especially diabetic preoperative patient in weight loss. Why we are asking the patient to lose weight preoperative? Because it's very important. I will show you some studies about this. Again, adjuvant liraglutide treatment in patients with persistent or recurrent diabetes after metabolic surgery, we have to use medication, and shows in this study how it increase and more effectiveness, especially post bariatric surgery. So again, liraglutide effective as adjuvant weight loss in patients with prior bariatric surgery, and there is many studies show that the effectiveness of this medication in reducing weight loss or patient weight preoperative. We will know why we are looking for this benefit of preoperative weight loss. Again, most of the problem now in bariatric surgery, and it become very clearly common, especially with the restrictive procedure, gastric band and gastric sleeve, patient weight regain. It is very clearly and obvious, especially common, as I said, with the band and sleeve up to 40%, 2 years, the weight regain, start patient weight regain. So this is another important example of showing the effectiveness of this medication to help the patient and adjuvant weight loss and maintain it when the patient postoperative weight regain. Postoperative pharmacotherapy augments surgical weight loss, which is clear from this study that using the liraglutide in postoperative patient weight regain, it will be effective. Again, in IFSO, we have a statement about the in these studies that saying that in the context of limited treatment option, liraglutide can be used effectively as an adjuvant to induce further weight loss in patients who have had partial response or inadequate weight loss or even weight regain. So it is one of the big important adjuvant for these patients. Therapeutic approach in weight regain, as I said, it is a very important here and a big issue post-bariatric surgery. So we reevaluate the patient, ask him lifestyle, physical activity, health, diet, sleep, and biorehearsism and stress reduction, because all these, as we said, it is one of the factors that causes weight regain or even weight gain. So consider conversion to a different option. This is not an easy decision to redo surgery. We have to try non-surgical, safe, effective technique if we have by lifestyle and surgical conversion. We have to think about it. But if we add more pharmacological therapy, which is less invasive and effective in this patient as a trial, and to convince him or try to have a good result with this non-surgical procedure. Preoperative management in this patient, very important. Bariatric surgery, as we know, is an elective. It's not an emergency situation. So metabolic patients, they have metabolic syndrome. We have to control these preoperative and BMI and risk factors, other risk factors, carry some complication. So we have to preoperative optimize all these problems like deficiencies, preoperative deficiencies, and other controlling diabetes. Controlling one of these important things we can do it is a BMI control. Why? Because in this study, which is very nice, showing that post-operative complication in bariatric surgery using age and BMI certification, a study using ACS and QIP data showing that morbidity and mortality increase on a predictable trend with increases age and BMI. So age, we cannot do anything, but BMI, we can control it. So reduction of BMI preoperative is very important because as much as the BMI go up, your complication will go. So one of these risk factors, it is reversible and controllable by diet or adding pharmacological therapy to reduce the BMI below 50 or 3 or 4-fold preoperative, which helped in reducing the complication. It was created from that study. Comparison of revision and primary bariatric surgery. In this study shows that revisional surgery is not an easy, it carries a higher complication. You will face up with more adhesions and the complication rate would be higher in revisional bariatric surgery, especially if we are going to do it for weight regain or inadequate weight loss. So revisional surgery also is not an easy. It carries about 41% higher complication rate than primary procedure. So it is not an easy decision and go and do another surgery for inadequate weight loss or even in weight regain. So weight regain, as you said, is an issue in our bariatric practice. So practical use of medical surgical combination therapy is an important pharmacological treatment after completion of surgical weight loss is a most promising strategy because, as you said, we can pre and post-operative control the weight by reducing the complication and we avoid revisional surgery. So pharmacological treatment works best for inadequate weight loss because it is controlling the appetite and also helpful. And the most important, it will delay or even can exclude revisional bariatric surgery because of its highly complicated surgery. It is wise to be a strategy after surgery as you would before surgery to use it for reducing a BMI and also to control the weight regain. Added new therapy after stable response to previous therapy reaching plateau. It is also, we can increase weight loss for the patient who is not responding very well. There is currently no good predictor for choosing the right medication for an individual patient. As we know, it is a behavioral disease and multifactorial disease. So drug can be effective in combination that are ineffective alone, which is we combine surgery plus medication, which is known in many other diseases. It will be very effective, especially in this patient. Are we going to think about lifelong use of successful approach or combination? Well, yes, why not? In our Saudi Society of Metabolic and Bariatric Surgery guidelines in 2019 and will be revised in 2020, we add in our guidelines that liraglutide, GLP-1 agonist can be used for management of class 1, 2, and obesity, and also effective in downgrading morbidly obese patients preoperatively and weight regain postoperative bariatric surgery. So it is in our guidelines and we approve it as a part of modality of treatment. So in I will just present you example of how to use it and where to use it. I have a patient, for example, a 58 years old male, hypertensive, weight 153, height 170, his BMI 53. So this patient, if you take him now to the OR, you will have a lot of adhesions and risk of intraoperative complication is higher. And we have many studies to prove that if you reduce a BMI, you will have a good result. And this intraoperative complication. So our target preoperative 140, that BMI 48 with 3 or 4, 5-fold downgrading his BMI would make a big difference in his cardiovascular, respiratory, and also intraoperative and abdominal cavity. So I need to lose 13 kg. This patient, I start him in liraglutide. In week 7, he lost 10 kg, and he was so happy. And still, we are looking to continue until he reach our target BMI for surgery. So in this way, you avoid surgery on a patient with higher risk. He becomes less risk for surgery. Again, in case 2, 42 years old, no comorbidity. In 2010, his weight was 143. Biliopancreatic diversion was done for him. He lost a very nice, good weight, but he went to another place for revision surgery in which they increase the absorption capacity of the bowel. So he gained weight. In 2020, his weight became 117. He came seeking for another surgery. So you expose this patient, first surgery, second surgery, and he went third surgery, which is unwise. So let's try with something more minimal and less invasive and it's effective. So 35-day post LGP, he lost, he became 107, and he was so satisfied and happy, and he said, I'm going to continue and maintaining and continue losing weight. So we avoid a major operation for our patient in third surgery revision. And we know at the end of the day, it is a behavioral disease or a behavior. It plays a major role in weight loss, weight gain, and weight regain. So this is 2 examples of the in bariatric surgery of using adjuvant liraglutide as a therapy. This is just summary about my patient. We use it in our clinic in bariatric surgery. We are seeing more patients with this BMI, for example, 35, 34. So we try to convince him that the surgery is not necessary. You have to try non-surgical treatment, and you will find your outcome will be better. At the end of my presentation, I would like to thank you, all of you, to your attendee. And if you have any question or concern, we are ready for discussion. Thank you. Yes, thank you, Dr. Assam. I think we have one question from one of our colleagues. He's asking, do you use it with the patient, diabetic patient? You are muted. Muted. You are muted. Unmute. You are muted. Still, we cannot hear you.
Dr. Mirza, Dr. Bataya is not muted. His microphone is on, so we guess he has some problems with his headphones. Maybe can you remove the headphones and try without them?
Try without. Remove it from the side.
You should unplug from the PC.
Yeah. I will try to write him a message. Anyway, it is very nice question.
And is it okay?
Yeah, now it's okay.
Yeah, there is no contraindication that it could be used even for diabetic patients. So liraglutide, yes, it can be used.
Yeah, another question came from my patient. Actually, she was a lactating lady, and she asked me, "I already postpartum now. You know, postpartum they gain weight." She asked me whether I use it. So I answered her. Until now, we don't have a clear, safe study about using it with lactating and pregnancy. So I request her to stop or not use this medication until we have a good answer. Other question, Doctor, how frequent you use this medication in your practice as a bariatric surgeon?
For the patient with the weight regain, actually, it is my first choice that I usually recommending for all patients to start with. But we have a minor issue, and this minor issue, you know, in governmental hospital, and it is not covered with the insurance. So it's little bit costly for the patient if they start using it. And this is, we are trying to solve it nowadays. And hopefully with NEPCO and the new regimen and with the new things that in Saudi Arabia regard supply for the medication and with fighting the obesity, it will start to be available with the MOH hospital.
Yes, I think even in private, it's a bit costly, but still, I think it is cost effective, which is the most important for the patient, avoiding a major procedure, and it's effective. But sometimes patients come to you after 1 month and they say, we don't have any effect. How you analyze these patients which they said, I have no benefit from the drug after 6 weeks or 1 month?
Always we have our psychologist and a clinical dietitian. We sit together and we start to have a multidisciplinary team in those patients, trying to see what's going on with his lifestyle and how he is eating habit, and all the environmental factors that we have described in the presentation. We try to solve it together as a multidisciplinary team. So according to that, we can start to find out where is exactly the problem to be solved.
Actually, they come to me also, but I always tell them I will not write you this medication because it's precious. And if you don't lose weight, that means you have a problem, not a drug. So I review with them. And before I prescribe this drug, I ask them, I want you to go 1 week, try with 0 carbohydrate. If you tolerate it, and I promise you in this week, you at least you will lose 1 to 2 kg. Then I can prescribe you the drug, because we don't want to lose the power and the name of this drug for patient non-compliant. So I give them this chance for, as a, even the first user, they come to me, I said, you have to have some time, trial 1 week, and then come back to me. And they always come with a very nice response. Then we start medication. The other important, I think, we have to show them how to use a technique of medication. I usually send them a very nice video and their WhatsApp and pamphlet. They can read it, because if I give them hand, they will lose it in the car, or they lose it in the market, or in their mother's house. So I send them WhatsApp, so they can read it and they understand it and come back to me after 1 week to be sure that it is working. And we have to analyze, especially weight regain post-bariatric, why they are gaining weight, and most probably it is behavioral. So I promise them that this drug will work if you willing to work. And most of them, they come happy, and if they comply. The only problem, they complain first week with the nausea and vomiting, and I open channel with them to follow with me every week, even with WhatsApp. But I could tell you 80%, they don't call me because they are happy until the next visit, or some of them, little they call me about the side effect and reassure them. One of these issue, they will tell you, if I get a period, do I have to stop and reuse again? I said it's nothing to do with the period. You can use it even with the your period. Some of them, they will ask you, if I stop 2-3 days, do I go for the previous dose or continue with my dose? So all these questions, they come from the patient. That means they are highly interested of this drug, and they find a very effective outcome. Do you have something like this feedback from these patients?
Yes, I have satisfactory really result, and recently I just also presented in the obesity club last week in Jeddah our experience with our patient who is being operated, and even diabetic patient. She is underwent sleeve gastrectomy. She has her weight loss, but then again she had weight regain. Actually, after the sleeve gastrectomy, she lost 20 kilograms, but again she regained again 10 kilograms of that. Unfortunately, she was so unsatisfied with the result, complaining that the surgery itself, it was not properly, and in spite of that, she is the one who was insisting to go for the sleeve. When we offer the patient sometimes other procedures, especially malabsorptive or bypass or any kind of bypass, they resist too much and they said, no, I don't want this kind of surgery. But later on, after she started on the grilletide, she did very well, and she started to improve her weight regain. And actually, she lost so far 26 kilograms. So it was synergistic with 6 kilogram additive to her initial sleeve. So really, I consider it part of my multidisciplinary therapy. What about Dr. Khalid for the patient of super morbid obese, the one that I just mentioned in category with the BMI of high, more than 50 or 60 BMI? Would you recommend to use for them such medication?
Yes, of course, because as I said, it is an elective procedure, and we have to optimize patient's condition like the other comorbidities. So we have the chance to downgrade him. As you know from all the studies, even if you 5 kg from losing preoperative weight, he will improve his cardiovascular, pulmonary, and GI tract. So we will have a very nice patient if he lose 10 kg, 15 kg. For me, the best, I send him to with the medication to the dietitian. I wish that they bring him with 10 or 15 fold. As you know, the surgery will be totally different. The outcome will be totally different than the patient with 62 compared to 55, the same patient. So I think it is very important to take it seriously. Surgery is not an urgent. We have to downgrade the patient, and it is no doubt it is carrying a very high complication with the BMI high. I have a question, I think came to me. Do you recommend this medication after 6 months of bariatric surgery? What do you think?
It's too early. 6 months, I think it is too early that you can say he already get the benefit or the maximum benefit from the surgery. I would recommend minimum, at least patient should wait for 2 years before they can start to say about weight regain, or they are not satisfactory. The problem that we are facing, patient is in a hurry. He wants to lose all of this excess weight in just a short time of period.
So when he start to hear about any other medication or any option that will give him a better result, he will be in a hurry to take it or to get it as early as possible.
Yes, I think this is a very great adjuvant therapy. We don't want to use it early because the surgery will do the job mainly after 1 year. If the patient starts losing slowly, we have to check his behavior. I have a question from our colleague, Dr. Haider Shurafa, is a very elegant and senior bariatric surgery, asking me how much the failure rate. Really, the failure rate not with the post-operative weight regain or downgrading the patient. The failure rate comes with the overweight patient, BMI less than 30. They have failure rate, but I will, when they come to me and they said it didn't work with me, I repeat question and ask him why. You have to know why, because the drug is drug. It is not vague. It's effective. So why it didn't work with you? When you sit with the patient and analyze, for example, I find one of the patient, it is really, they inject themselves while the cup is closed and they don't know how to use. So this is part of our education. And these patients, sometimes they fed up from nausea and vomiting from the first or second week. We have to reassure them and encourage them. They come and they stop using it because all what they need, 10 kg or 12 kg, for them, it doesn't work to have this minimal side effects. So they quit or they said it didn't work. Other one, when I analyze with them, they are still sweet eaters. So in spite of I ask him, I want you 1 week pre using the drug, promise me stop the sweet and come, they go back. So it's a failure, it's higher with the low BMI, not with the high BMI. High BMI, they really want to, they like to have a result and outcome. Low BMI, they are comparing their between the drug or diet or exercise. So they are not 100%, I can say, serious with me, and they want to comply with the drug. Some of them, they stop and they go back. So, and also the technique, we have to check. They are doing it right time, right dose, and also the technique, very important.
Totally agree.
Do we have any other questions? I will check. So I think we have to be very careful with these patients because I always tell them this is effective. And you ask about complication, like we heard about pancreatitis, we heard about cancer inducing. We always reassure them and we tell them it is different than surgery. It is different than intragastric balloon. It is different than glycation, endoscopic glycation. It is invasive, and if you have something, we have to go back. This drug, if you have any side effect, you can discontinue, you can stop. But we don't have the only contraindication we ask them to avoid if you have a thyroid issue and family history of papillary carcinoma. We have to be careful, and always I do for them preoperative TSH function, and they take career history if they have a family history.
Yes, usually the side effect when they increase the dose every week, they have some sort of this side effect. And this is, I think, the major issue that why people they stop taking the medication.
We have the pool. We can start, Dr. Sam. Yes, we can start. Yes.
Okay. So in your current practice, how often do you use the anti-obesity medication? Please select one of the following: always, sometimes, occasionally, rarely, or never.
Can see the answer if we have. So very interesting. Sometimes, occasionally, sometimes 27%. Actually, the number is 23%. I think we have to re-educate our surgeons, and we have to take more studies and research about this. But expected answer. We have next one.
So after listening to our talk, you would consider using the anti-obesity medication in your clinic? Do you strongly agree, neutral, disagree, or strongly disagree? So I think we succeeded with our mission, Dr. Khalid.
Well, still it is nice.
69 agree.
Yeah, and I think I was from the people who I was not aware about the medication, but it is there. I think it is a weapon, and we have to use it, and it is safe, which is good.
So I think it was a great opportunity that we are sharing with our colleague, especially the surgeon, regard any other modality that could help us. We always try to help each other, and especially using all kinds of modality.
I think Dr. Muhammad Dawahab, also our colleague, a very great bariatric surgeon in the south or north part of the kingdom. He's asking the question of using Saxenda with the diabetes. You have, I think you answer. It is not bad to re-answer this question, Dr. Isam.
Yes, there is no contraindication that it could be given for the patient. The only problem that they start to have some sort of hypoglycemic agent. The Saxenda, I know the receptor, it's the same as the one that they are using for the Victoza. The Victoza is targeting mainly the pancreatic island more. With the Saxenda and these higher doses start working mainly on the brain. But only cautious from those patients, try to ask them not to take the medication or the Saxenda during evening time. It's recommending that it should be in the daytime, so that to avoid any hypoglycemia attack if they are taking their own medication for the oral hypoglycemic agents.
How long you are going to use the medication for this patient? This is another question from Dr. Muhammad.
Always it's recommending the first 6 weeks until they will be on the maximum dose. After that, you will start to see and analyze and audit their weight loss. If their weight loss is satisfactory, that's almost reaching to 1 to 2 kilograms per week. And with the total of the 6 weeks, the maximum that they are reaching, at least they lost 4 kilograms. That means, yes, it is effective that you will continue with them. But if it is not, and they are not losing any, you have to bring them back and see what's going on, sit with them again, see what they are eating and all their eating habits. And according to that, you will re-decide if it is suitable for them to continue, or we have to look for other modality.
Yes. Again, in our protocol, we have to be sure that it is going to work with this patient. We have to prepare this patient reuse, and then we give him trial of 1 month, 5 weeks. It is not a trial. It is actually to reach the maximum dose, as you mentioned, and we continue another month and maximum 3 months to reevaluate again. But usually I prescribe them for 3 months. I ask him, don't buy the drug the all 3 months. Start with first kit, then we continue second kit and third kit. If we succeed, we continue. But do we continue it for life or until you reach your target weight?
Usually the recommendation is up to 1 year, and almost this is what is in the literature and the studies. And I think it is just a help tool. So all what we need from those patients to change their lifestyle, their eating habit, they can reach, and then they will be endured on. So nobody would like or prefer to take a medication for lifelong. And as we just mentioned earlier, the cost of that medication, it will be a burden on him. He want to get rid of a chronic disease, and he doesn't want to add one more on his medication list.
Yes, I agree with you. I think, do we have another question? I think we have all the questions. If you do like to add any comment before we. Yes, very nice question. Do you consider using Saxenda with adolescent? What is the age limit?
It's, as it's mentioned in the pamphlet and recommendation of the drug, 18 plus, not beyond that. So it's really a little bit difficult to use such medication in adolescents or below 18 years of age, according to the recommendation.
I think yes, not because of the side effect only. These adolescents, they are not responsible. We cannot depend on them. They will not comply with whatever you say. It's difficult to comply, and they have to have their guardian, their parents around them, and simply they can refuse their instructions. Simply they can go and eat sweet. So it is the issue of controlling. Even in bariatric surgery for adolescents, it is very difficult. You have to evaluate and be sure they are going to be compliant. The same like this drug, other than side effect or complication, they are still adolescent and difficult to control. This is also another important issue, but they are not recommended below 18. We not until now, but there is a on the horizon there is studies or promises that there will be new studies supporting using at lower age, but until now we have stuck to our guidelines and instruction not less than 18 years until now. Maybe within a few months we come with the new literature and evidence. Yes, I think we, let me see, do you have any question here? Yes, question. I think we don't have any more questions from audience. Okay. So last comment, Dr. Assam, before we leave. Anything you'd like to comment before we leave, Dr. Assam?
I would like to thank the organizing committee, and it is a pleasure and honor to be with our IFSO MENAC president and having this closing session for the second day almost with this symposium. And we would be happy that at least the pooling that will change their minds for our colleague, the surgeon, start to use a new tools, a new budget that it can really help you, especially in those cases. You just see earlier in the videos how much revision cases is ugly, and it is sometimes unsatisfactory. It's demanding for us as a surgeon, plus it is a demand on the patient. But if you can use such gadget with your hand, it can be more, make your life more easier, make your patient more happier. Thank you.
Thank you very much, Dr. Assam. I would like to thank you all the people who shared us and to make this Congress successful. And a special thank for Novo Nordisk. And thank you very much, and see you in the next meeting. Thank you.
Thank you.